to Envision New Mexico this afternoon, and we do have a few items to cover before we get started. The session is being recorded at this point, so please do not include any confidential patient health information during the session, particularly when discussing any cases. And I wanted to let you know we are broadcasting live, and our audio is being broadcast. There's information on how to mute and unmute your audio and your video. We would love for you to be on camera if at all possible. And in order to receive CMEs or CEUs, you do need to announce your name on the live session. So you can do that through the chat box or by unmuting using those buttons that you just saw and will again in a moment, and letting us know who you are and where you're from. And there's those buttons once again. Our disclosure and accreditation statements are on screen right now, and we're required to present them in order to give you the CME and CEU certificates. We do want to remind you that handouts are available on our website. Go to envisionnm.unm.edu, go to our calendar, and you can download them there. It's the same place where you registered for the live session. We do offer case consultations here at Envision New Mexico for many of our initiatives with telehealth, and Molina and Blue Cross Blue Shield New Mexico has partnered with us to give you reimbursements for those case consultations. So get in touch with either Michelle Widener or myself, and our information is at the end of this slide set. So please give us a call or an email to ask more information about that. And this is your opportunity for roll call. So anybody who's out there on the live session, feel free to unmute and let us know who you are, where you're from, or you can use the chat box. And at this point, I will hand it over to Kirsten Bennett, our facilitator for today, who will introduce our presenter.
Thanks so much, everyone, for attending. It's my pleasure to introduce Monique Vallabhan, who's a doctor of nursing practice and a family nurse practitioner. She's a new member of our team here at Envision and an expert in overweight and obesity as well as asthma. And we are going to be using her expertise around asthma management. And please welcome her as she tries to run through the newest guidelines in 20 minutes or less. Do remember that we have a host of experts here, and I'm sure Monique would be open to questions or comments at the end of the session. And then if there are further questions and comments, feel free to send those to Kevin or Michelle, and we can get them off to Dr. Vallabhan. So thanks so much for being part of our Envision team, and thanks for presenting today.
My pleasure. All right, so the topic for today is guidelines for primary care asthma in New Mexico. I'm going to provide a brief overview of the GINA 2017 and National Heart, Lung, and Blood Institute guidelines from 2007 and how the two fit together. I have no conflict of interest to disclose, and this work was funded by Fronteras Research Grant. We will discuss these topics in this presentation to increase your knowledge and comfort with addressing these objectives. In your practice, do you assess asthma control and severity? Have you confirmed that your patients have an asthma action plan, and do you revise that action plan regularly? Do you regularly review inhaler skills and technique with your patients? Did you know that new asthma treatment guidelines recommend a cycle approach to adjusting treatment? The burden of asthma in the United States, the prevalence is 8.6% in our children, according to the Centers for Disease Control. This is the leading chronic disease in children. The prevalence in New Mexico is about 9%, or about 47,000 children, according to the New Mexico Department of Health epidemiology report in 2014. 10.8% of our children in the state who have asthma are males, 7.3% are females, and among high school students, 14.2% are females and 11% are males. This also affects disparate populations in adults, with African Americans being most affected by asthma. Symptoms should be assessed at the diagnosis visit, and this is done through assessing control. And control then guides your initial treatment and your ongoing treatment. For this presentation, we will not discuss diagnosis because that will be covered in a later presentation. Both the GINA and the National Heart, Lung, and Blood guidelines indicate assessing severity control and responsiveness, and assessing for and reducing the effect of comorbidities. So after a diagnosis and you're assessing a patient with asthma, there's three components to the assessment. The first is assessing asthma control, the second is assessing treatment, and the third is assessing for comorbidities. Included in asthma control is symptom control over the last 4 weeks, identifying risk factors for severe poor outcomes, and then lung function at the start of treatment, and then periodically thereafter. Included in treatment assessment is to document the current treatment plan, observe inhaler technique, assess adherence and side effects, and ensure that the patient has a written asthma action plan. Ask about the patient's attitudes and goals for their asthma and medications. And the third component of assessing a patient with asthma after diagnosis is to assess for comorbidities. These comorbidities include rhinitis, rhinosinusitis, gastroesophageal reflux, obesity, obstructive sleep apnea, depression, and anxiety. According to both the GINA and the National Heart, Lung, and Blood Institute, the long-term asthma management goal is control. According to GINA, control is defined as the extent to which the effects of asthma can be seen or have been reduced or removed by treatment. Asthma control has two domains, including symptom control and risk factors for poor outcomes. We assess symptom control at diagnosis and again 4 weeks after treatment. And we identify other risk factors for poor outcomes. Having one or more risk factor increases the risk of exacerbations, even when symptoms are controlled. This asthma symptom control tool proposed by the GINA is a simplified questionnaire, and it only involves 4 questions about symptoms with a risk assessment that will follow. This is condensed compared to the asthma control test, for which we are familiar and which is recommended by the National Heart, Lung, and Blood, along with other assessment tools that they have. So both the GINA and the National Heart, Lung, and Blood provide tools for assessing and determining control. GINA is condensed and it's quite a bit more simplified and includes well-controlled, poorly controlled, and uncontrolled categories, whereas the National Heart, Lung, and Blood includes well-controlled, not well-controlled, and very poorly controlled categories. So as you can see, there's 4 questions up there, and those questions will look very similar because the first 3 are pulled right from the asthma control test. The 4th one is similar to one of the questions on the asthma control test, and it's an assessment of the last 4 weeks prior to your visit with the patient. All negative responses would indicate well-controlled, 1 to 2 positive responses would indicate poorly controlled, and 3 to 4 positive responses would indicate uncontrolled. The asthma control symptom tool is used in tandem with a risk assessment at the time of diagnosis and thereafter. This is slightly different than the National Heart, Lung, and Blood, where the GINA guidelines indicate that you should do this at the time of diagnosis, and it's actually quite expanded compared to the National Heart, Lung, and Blood for the risk factors. And you'll see that in a few minutes when we get into it. So risk factors are factors that increase future risk of having exacerbations, loss of lung function, or medication side effects. You should assess at diagnosis and then periodically. If possible, you should measure forced expiratory volume in 1 second at the initial treatment. And that's done through spirometry, and then periodically thereafter. So variable airflow limitation can be confirmed using peak flow meters, and this is recommended and proposed by the World Health Organization as an essential tool in low resource settings. And it can be used according to GINA for part of the documentation of diagnosis and symptom control thereafter. Based on the current evidence, long-term peak expiratory flow or peak flow monitoring is now generally only recommended for patients with severe asthma or those with impaired perception of airflow limitation, because at least it gives you some additional information. It's not very reliable for the long term, so in National Heart, Lung, and Blood really didn't have a lot of language to include it in their guidelines, but GINA is including it as an additional tool for low resource areas. So peak flow symptom monitoring or a combination can be used, and self-monitoring is the emphasis for both National Heart, Lung, and Blood and GINA. All right, so the risk factors include inhaled corticosteroid not prescribed or poor adherence or technique, high SABA use greater than 1 200-dose canister per month, which actually increases risk of mortality, and more than 2 days per week of SABA use not to prevent exercise-induced bronchospasm indicates inadequate control. Another risk factor for poor asthma outcomes is low FEV, especially greater than 60% predicted. Major psychological and socioeconomic problems, exposures like smoking and allergens, and comorbidities, especially obesity, rhinosinusitis, confirmed food allergies. These comorbidities can increase the symptoms of asthma. Another risk factor for poor outcomes include pregnancy and one or more severe exacerbation in the last 12 months. A final risk factor for poor asthma outcomes is risk for medication side effects, which includes frequent oral corticosteroid use and for the long term, and high-dose inhaled corticosteroids. GINA and the National Heart, Lung, and Blood categorizes asthma severity consistently in 3 categories: mild, moderate, and severe asthma. However, there is different nomenclature in the GINA guidelines in that intermittent and persistent terms are not components of severity, and you don't see it throughout. However, for ICD-10 purposes, intermittent and persistent nomenclature is still needed. That is consistent. So severity should be assessed retrospectively from the level of treatment required to control symptoms and exacerbations. Severity is also used to describe the intensity of the asthma symptoms. So you can see in the mild category, it's well controlled with step 1 or 2, moderate is well controlled with step 3, and severe requires step 4 or 5 treatment to maintain control. Assessing uncontrolled asthma and severe asthma. Check inhaler adherence and technique, confirm diagnosis, assess risk factors, check for and remove or reduce when possible, including smoking, beta blockers, non-steroidal anti-inflammatories, and aspirin use, allergen exposure, and comorbidities such as rhinitis, obesity, GERD, depression, and anxiety. Consider stepping up treatment and refer to a specialist if it's still uncontrolled after 3 to 6 months on step 4 treatment, or sooner if symptoms become more severe. As mentioned previously, both the GINA and the National Heart, Lung, and Blood asthma management goal is control. Control is twofold. So National Heart, Lung, and Blood defines it as reducing impairment. They use that word, and GINA uses controlling symptoms. They include the same elements: preventing chronic symptoms, require infrequent use of a SABA, and maintain near normal lung function and normal activity levels. Both recommend reducing risk as well, including minimize exacerbations, minimize emergency care and hospitalization needs, prevent loss of lung function. So if we're not careful in treating these patients, they can have reduced lung growth as adults. Minimize adverse effects of therapy is the final risk reduction element that we want to consider. The GINA management cycle is simplified compared to the National Heart, Lung, and Blood guidelines. It involves a continuous triad cycle for children greater than 6 years of age through adulthood, whereas the National Heart, Lung, and Blood breaks it down into 3 categories: 0 to 4, 5 to 11, and 12 or greater. The continuous cycle means that treatment is adjusted in a continuous cycle based on the patient response to the treatment, and this begins at diagnosis. The cycle approach is used at diagnosis, as I just said, and continuously. So that's a little bit different than the National Heart, Lung, and Blood. They have one approach at diagnosis and a different approach for ongoing management. So this really does simplify things.
So in this case, each time you're using the same cycle. I
At
just want you to do every step at every visit.
That's exactly correct. And then you reduce risk for severe outcomes or poor outcomes. The continuous cycle starts with the assessment, and that involves diagnosis, and that includes symptom control and risk factors, inhaler technique and adherence, and patient preference. The second step is to adjust treatment, which involves asthma medications, along with non-pharmacological strategies, and to treat modifiable risk factors. The third step is to review the response of the treatment, and that involves the symptoms, which includes exacerbations, side effects, patient satisfaction, and lung function. And again, as Kirsten pointed out, this happens at every visit. At the initial appointment, both the GINA and the National Heart, Lung, and Blood have consistent recommendations. Record evidence of diagnosis if possible, assess asthma severity through control, assess lung function when possible, initiate medications and demonstrate use, develop a written asthma action plan, and that's the cornerstone for both National Heart, Lung, and Blood and GINA. Schedule the follow-up visit. So up there where I said assess asthma severity, severity is assessed through the asthma symptom control tool that we discussed earlier. Initiate the controller treatment. So for a regular low-dose ICS or inhaled corticosteroid is recommended for all patients with a diagnosis of asthma and any of the following symptoms. So asthma symptoms twice or more a month, waking due to asthma once or more a month, and any asthma symptoms with an additional risk factor for exacerbations, which includes oral corticosteroids for asthma use in the last 12 months, low FEV1, and ever in the ICU for asthma.
So on an asthma action plan, this would be in your green section, your everyday section?
This would be in the everyday, yes, exactly. So this is where we would start, either with a controller or a regular low dose, if any of those 3 categories or those 3 bullets are present. That's correct. Initial controller treatment. So other things to consider when initiating a controller. Start at a higher step, or consider that if the patient has troublesome asthma symptoms on most days, is waking from asthma once or more a week, especially if there's a risk factor for exacerbations. Or if the initial presentation is with severely uncontrolled asthma or acute exacerbation, give a short course of oral corticosteroid burst for 3 to 5 days and start the regular controller treatment at a high dose inhaled corticosteroid or a medium dose inhaled corticosteroid with a LABA. So you won't find this in the GINA. I put this together to simplify the model and to be able to understand how all the parts go together. Step 1 and step 2 is for mild asthma. Step 3 is for moderate asthma, and step 4 and 5 is severe asthma. They do categorize the steps 1 through 5, and that is different than the National Heart, Lung, and Blood, which had 6 steps. And so what they've done is they've combined some of the steps and really simplified again, and this uses grade A and B evidence. So step 1 would be a SABA as their primary inhaler, and that's for rare symptoms, no nighttime waking due to asthma, and no exacerbations in the last 12 months. Step 2 is, in addition to the SABA, is a low-dose inhaled corticosteroid, and I included the criteria in that box underneath there. Step 3 and 4 have the same criteria, so the difference between making a decision whether you would start a patient on step 3 or 4 is severity. So step 3 is a low dose inhaled corticosteroid with a LABA. Except for children aged 6 to 11, what's recommended and preferred is a medium dose inhaled corticosteroid. Step 4 would be a medium or high dose inhaled corticosteroid and a LABA. The other component of the treatment that's different is you have an alternative of, instead of using a SAVA as a rescue inhaler, you can also use a low dose inhaled corticosteroid combination with formoterol, and that's new according to the GINA guidelines. Based on evidence, it improves asthma function, or pardon me, asthma control quicker, and it's longer lasting. So an example would be Symbicort, which is budesonide and formoterol. Formoterol is a long-acting beta-2 adrenergic receptor agonist. And the way it works is it relaxes smooth muscle in the airway, and it's rapid onset. So step 5 then would require further investigation and referral. After starting treatment, review the response in 1 to 3 months for the symptom control, and then every 3 to 12 months. Now, the reason you review the response in 1 to 3 months is lung function starts to improve within days after starting an ICS, and it reaches a plateau after about 2 months. So that's where 1 to 3 came from, and that's consistent with the National Heart, Lung, and Blood Guidelines as well. Frequency depends on the initial level of control, response to treatment, and the patient's ability and willingness to engage in self-management with an asthma action plan. Stepping up asthma treatment. Sustained step up for at least 2 to 3 months. This is in the presence of symptoms and or exacerbations that persist despite 2 to 3 months of controller treatment. For these patients, you would assess technique, adherence, modifiable risk factors, such as secondhand smoke. If they have a food allergy, you want to make sure, a diagnosed food allergy, you want to make sure they have an EpiPen. Also assess for comorbidities, comorbidity symptoms such as allergic rhinitis. You would also step up for the short term or 1 to 2 weeks during viral infections or allergen exposures, and that would also be included in the asthma action plan. Day-to-day adjustment is for those with the prescribed low-dose ICS formoterol as the maintenance and the reliever, which we saw in step 3 and 4. Stepping down treatment. Consider stepping down the treatment if the patient has good asthma control that's been achieved and maintained for at least 3 months. Choose an appropriate time to step down. You don't want to step down during an upper respiratory infection, when a patient is traveling, or known pregnancy. Document the baseline status, which includes symptom control and lung function. Provide a written asthma action plan. Monitor closely and schedule a follow-up visit. You would step down to reduce to an ICS dose by 25 to 50% at 2 to 3 month intervals, progressively decreasing. Follow-up visits. Assess and monitor asthma control. Review medication technique and adherence. Assess side effects. Review environmental control. Maintain step up or down medication. Review the asthma action plan. Revise as needed, and schedule a follow-up appointment. In conclusion, the overview of GINA 2016 versus the 2017 guidelines and the National Heart, Lung, and Blood. The current evidence indicates there should be changes in the frequency in assessing lung function after diagnosis. Additional alternative treatment options are also included. I only mentioned one of several other alternative options that are available, and I'll cover those in the treatment presentation that we'll do later. Treating chronic rhinosinusitis improves nasal symptoms, but does not generally improve asthma outcomes. That's based on current evidence. The potential effect of poorly controlled asthma on children. The current evidence indicates that ICS use may reduce growth velocity in the first 1 to 2 years, but this is not progressive or cumulative, with little effect on adult height. So that's really great because we were worried about that in the past. The new evidence also gives us some information about lung function trajectories. Children with persistent asthma may have reduced growth in lung function, and some are at risk of accelerated decline in lung function in early adult life. That's significant. So that also is an indication that we need to be really aggressive in treating these patients. So overall, there are more similarities than differences between the National Heart, Lung, and Blood and the GINA guidelines. However, the GINA guidelines are condensed to be more simplified and approaches treatment through an ongoing cycle approach. And GINA recommends treatment for children ages 6 through adult with a consistent approach. Peak flow monitoring, according to the GINA guidelines, can be used as part of diagnosis and to assess response to treatment in low resource areas. It can also be used to evaluate triggers for worsening symptoms or to establish baseline for action plans. After starting an ICS, the personal best peak flow from twice daily readings is typically reached on average within 2 weeks. Both the GINA and the National Heart, Lung, and Blood have consistent recommendations that long-term peak flow monitoring is now generally only recommended for patients with severe asthma or those with impaired perception of airflow limitation. The emphasis for both National Heart, Lung, and Blood and GINA is self-monitoring, either in combination with the peak flow or without. So I'd like to reflect on the questions that I asked at the beginning of this presentation. And after today's presentation, I like to ask what was interesting, what was learned, and how will you apply this information to your clinical practice based on these 4 objectives. The first one, assessing asthma control and severity. An asthma action plan, make sure it's in place and that you revise it regularly. Review inhaler skills and technique with your patients. And then the final point is the cycle approach, which is different with the current guidelines compared to our previous guidelines. Did you have any questions?
I do, but did we get any questions from our audience
We
here?
did have one person join us, and I'm going to give that person the ability to talk to us. And so, Holly, just wanted to give you the opportunity to ask any questions that you might have. You may need to unmute yourself, or you can always use the chat box. I did send you a chat, and we can read them aloud here.
So while Holly is thinking of a question and typing, I have a couple questions. So it seems like in terms of what did I learn here, it seems like what's changed is the every 3-month time frame. So I guess my question is, in past when we've worked with providers, you know, the minimum of what we measured on our medical record reviews was, did they have a planned asthma visit at least every 6 months? Mm-hmm. So it sounds like now the guidelines we should be asking, did they have a planned asthma visit once every 3 months? In other words, not counting those ones where they came in because of illness or exacerbation. Is that a correct assumption?
It's correct, and then that can be modified based on control. So until they've reached control, you bring them back every 3 months. And once they have control, that can be extended.
Okay. So that may be something different that we have to talk about with our providers. But then I have another question. Based on your experience, how often do you think people actually hit that mark, you know, every 3 to 6 months for planned asthma visits? In other words, they probably came in, they come in once a year for their sports physical, and then you never see them again. I mean, is that?
It is very common. However, last year I had a patient that happened with, and he came in and we thought he was having an asthma exacerbation, and it was pretty severe at the time, so we treated him with a nebulizer and were able to get his asthma under control after about an hour of asthma symptoms. But he had not used his controller for more than a year, and he actually forgot about it. And I called his dad, and his dad forgot about it. And yeah.
So it's an example of what not to do.
Exactly.
Don't forget.
So it is really important, even just having the appointment. If they don't show up, they're getting a reminder call for the appointment. So it does bring awareness. Everyone's busy. No one, I'm sure Dad, this was not on his radar. Everybody's working, busy, just trying to meet all of their responsibilities. So scheduling the appointment is important, even if they don't show up. A reminder call, rescheduling, and continuing to try, and documenting that they didn't show up, you made a call, you talked to them. All of those things, I think, play a role in helping to get the patient in there.
Okay. I think the other thing that I thought was interesting is that using the positive, saying to a family that when we start this, you're probably going to see big changes in the first 2 weeks. I mean, part of working with a chronic disease is that it's frustrating because you feel like you're trying to treat your chronic disease forever and you never feel better. So
yeah,
I think that's a really positive thing to be able to say.
Most definitely, right. That they will see an improvement within 2 weeks, and they plateau on the lung function right about 2 months. That's really wonderful.
So Holly, we're glad you're on, and we're waiting for some questions from you. But I have a question to you, since you've been working actively with your patients on trying to use our pictorial asthma action plan as a patient engagement tool. In other words, a reminder of the things that we talk about in your visits. And maybe you can share with us how that's helped. Do you feel like you're getting closer to maybe some of these guidelines?
And Holly, I'm going to attempt to unmute you from here.
Hopefully we didn't lose you. So while we're waiting, one more question I have on my list here, and we kind of talked about it before your presentation, but this idea of peak flow. So we, Brandon Bell and I went to Head to Toe this year. We presented the initial work that we're doing on this pictorial asthma action plan, which Holly is our first participant in that little research project. And we had a room full of school nurses who are the ones that typically have to deal with this because most schools don't have a school-based health center. So kids are coming in because they're not doing well. And so the old school way of doing this is they felt like they had to have a peak flow to actually be able to use the asthma action plan that they had in front of them. So tell us some more about that approach.
So that is absolutely not different. We don't need a peak flow to determine control and severity. It's proposed as an alternative in low resource areas where they cannot travel hundreds of miles to have a spirometry done. And both GINA and National Heart, Lung, and Blood emphasize self-monitoring over peak flow. It can be used in combination, but the emphasis is on self-monitoring. So you have patients who don't really do a real good job of understanding or knowing when their symptoms are active. In those patients who are not sensitive to their airway limitations, they would be a good candidate. But there's vast variability in peak flow based on the different monitors that you use. So if you use one at home and you use a different one at school, you're going to get different results. So they're not real reliable in the short term and less reliable in the long term. However, if that's all you have, it's better than nothing.
But for the school nurse who has the kiddo who comes in, you would just go to their asthma action plan.
Exactly.
And just, if the kid says, this is what I'm
That's
noticing,
better.
That's better.
It is better. And the reason it's better is because the emphasis is on self-monitoring and their symptom control. And so if they do a peak flow in the nurse's office and the kid has a different peak flow machine at home, you're going to get two different numbers. And so it might look quite different, and it might change the treatment plan based on those results. So symptom monitoring is better.
So Holly has jumped in to answer the question about the pick app. I think I have 12 patients now and have gotten an overwhelmingly positive response.
Wow, wonderful.
That's good. We're gonna bring Monique around to our way of thinking about less words and more pictures, as a way of, it's a refrigerator magnet quality. In
I
other words,
love it.
stick it on your fridge. So we'll see. Maybe you guys should chat at some point and see how
Okay.
it works. So I did have a question though about the age of the kids. So it sounds like the GINA guidelines have made it easier. You know,
Yes.
6 and up, you just do the same thing for everybody instead of having to remember.
That's exactly correct. Except for in one of those steps, there was a caveat there for ages 6 to 11 in the treatment. In step 3, they recommended something a little bit different. Or was it step 2? Let me look.
And let's see, what else has she got up there?
Question about severity.
Yeah.
Our patients move around between providers a lot. How is severity determined if one is not initiating but continuing treatment initiated by another provider?
That's a great question. So with the GINA guidelines, they have a, can I go back
You
on the
can go
mouse?
back.
Oh, yeah.
Here, let me have that.
Let's you.
So
That's a great
I'll show you, Holly, where you can do that. So the first thing I'm going to show you is this continuous cycle. So whether they're there to see you at diagnosis or a follow-up visit, this is the approach you will use regardless of the reason that they're there, except for exacerbations, right? And the treatment would be different, but the approach, the cyclic approach, would be the same. So the way you're going to determine severity, let's see, am I going the right way? Yep. Right here. So the asthma control test, I think, I don't remember how many questions it has, but I think there's 20 questions on there. There's 4 questions on this. So the GINA guidelines recommends assessing symptom control, and this will tell you severity. And it's based on these 4 questions. They recommend the symptom control test along with the risk for poor outcomes evaluation. So that's what you would do. If the risk for poor outcomes is assessed at diagnosis, it just has to be done every 1 to 2 years after that, unless they have an exacerbation. And then you would try to look to investigate what might be causing that exacerbation, because these points in here may influence that. And I do want to point out something about obesity, that obesity can mimic asthma. So it would be really important. Obesity and asthma are comorbidities that frequently are associated with each other. But we want to be sure that it is asthma and not just the symptoms associated with obesity. So determining that would be included in the diagnosis, which we'll talk about later, but typically it's reversible airway obstruction is the diagnostic criteria. What did she ask? Can you download this slide set on our calendar?
Yeah,
That's me. I'm just letting
just
you know.
reminding her.
You can get these slide sets
You
Holly,
can
from
do
our
it.
calendar. If you have any
Yeah.
trouble, just let me know.
Yeah, and then is it acceptable to give her my email if she has additional
Yeah,
questions?
absolutely.
Yeah, so you can contact me directly.
And Kevin can put that in there.
Yeah, I'll ask Kevin to send my email to you. So the GINA guidelines are about 200 pages long, and the National Heart, Lung, and Blood are another 300.
I like this version better.
So I'm happy to share with you this version, and I read it extensively, and if you have additional questions, I'm happy to investigate it for you.
So I have a question that's sort of unrelated to this, but it's related to asthma. Going back to your high school students. The being cool, uncool, having asthma, and potentially even going in and saying that you have symptoms associated with asthma because you've heard from your friends on the track team that when you have an inhaler, you perform better.
So that's interesting. I have not experienced that before in clinic, and I am in a school-based health center and I see kids pretty regularly. What I would focus on is the risks of taking medications that you don't need. Using a SABA when you don't need it really makes you feel anxious. It doesn't feel good, and it makes you feel irritable. So I would emphasize that and focus on taking things or using medications that your body does not need and how it will respond to that. Wow, I've never heard that.
It's happened.
So something else, and I will talk about it, but with Holly on here, I'd like to say that that particular patient that I discussed with you that had not treated his asthma for more than a year, I continued to treat him over the course of 4 months, and he did not get better. In clinic, he looked stable. His peak flow was fine. I did do that. His O2 sat was fine. His heart rate, blood pressure, all his vital signs were normal. Color was great. Everything looked normal on exam, but he said when he was running cross country on the cross country team, he'd get some pretty severe symptoms. And he was really worried about it. Despite stepping up his treatment and continuing along the course, it didn't get better. I sent him to see an asthma specialist, and he had vocal cord dysfunction.
Wow, interesting.
And we'll cover some of that in the diagnosis presentation, which is a differential diagnosis, and it's something to consider if your patients are not getting better. And in the GINA, they're recommending referral a lot sooner than what I saw in the National Heart, Lung, and Blood to reduce risk of mortality.
Right. Wow, that's interesting. Well, I don't have any more questions. So, Holly, do you have any more questions for Dr. Vallabhan today? And if not, you know, she has her email up there, and she has kindly given her permission to send questions. If you don't feel comfortable doing that, you can send them to Kevin, and then we'll make sure that she gets them.
Definitely. I'm happy to answer any questions. With the spacing on that camera.
Okay, well, thanks so much for participating today. And Holly, please share that this presentation is available on our website. It'll be available in the recordings on our webpage, but soon will be up on our online learning platform under Moodle for Fronteras, which is our school-based health center telehealth initiative. And CMEs will be available for anyone who uses the Moodle platform in addition to the live presentation. So thanks so much.